Hi everybody, I'm Dr. Safwan Al Bayati, consultant ophthalmologist, phaco-refractive surgeon, medical director of New Vision Eye Center Dubai. And here we are today. We need to discuss an important subject that I feel that a lot of doctors they need it, a lot of us we need it, especially when we are losing the support for an intraocular lens when we are implanting this lens. It is the secondary IOL implantation. So I found that we can do a screening and full discussion, comprehensive discussion for this subject. And this is the first episode for a secondary IOL implantation. We will follow this episode with the other type of secondary IOL implantation, but today we will give an introduction and we will discuss one of the technique, which is the Yamane technique. And in the second episode, we will discuss the fourth lunge technique. And in the third episode, we will discuss the scleral fixation using Jortex technique. And that's the main three at least used in the world, main common used. But we will have an idea about the history, how it started, when it started, and so on. So when we are discussing the secondary IOL implantation, by definition, it's an implantation of IOL in a poor capsule support that might happen in a complicated cataract surgery, dislocated IOL capsule bag complex, and congenital or acquired dislocated human lens. If we will go to introduction of secondary IOL implantation, we'll see that the first wave of secondary intraocular lens to be implanted was the anterior chamber intraocular lens. Secondary intraocular lens can now be implanted in a variety of anatomic location with the different techniques used to support the lens, like for example sutured IOL using Jortex suture that we will discuss it in the third episode, Yamane technique that we are discussing here in this episode, and glued IOL and iris claw and etc. Specifically, sutured IOL and intrascleral fixation technique have been gaining popularity, especially in one study found that 538% increase in secondary sutured IOL technique from 2000 to 2013. However, with the advent of several new techniques, there is no clear guidance for the best techniques for secondary IOL placement. This course aimed to discuss Yamane technique in the first episode. We will discuss the indication for use and surgical modification and other consideration. I don't have any financial disclosure, and this is our reference for this presentation. The object of this discussion, the idea behind the idea behind Yamane technique is to externalize the haptics of the three-piece IOL using thin-walled 30 gauge or 27 gauge needles through two transconjunctival sclerotomies. The haptics of the IOL are carefully laced into the lumen of needles using intraocular forceps. Then, the needles are used to externalize the haptics on the conjunctival surface. Next to that, the low-temperature cautery is used to make a flange at the end of the haptics. This flange or bulb prevents the haptics from prolapsing back into the posterior chamber using a scleral tunnel. And the three-piece IOL is thereby fixed efficiently in the posterior segment in the absence of capsular support. The technique of Yamane for secondary intraocular lens implantation in the absence of the capsular support have been accomplished by using an anterior chamber. The secondary, this is just give historical issues, have been accomplished by using an anterior chamber IOL, an iris fixed IOL, and transscleral suture posterior chamber IOL. The transscleral IOL suture technique using 10-0 nylon or 10-0 polypropylene has an advantage over the other techniques, the anterior chamber technique, which can cause corneal endothelial cell loss and glaucoma and peripheral anterior synechia. However, suture erosion through transscleral fixation using 10-0 polypropylene and breakage remain significant concern when using transscleral IOL sutures. Suture breakage was observed in 27.9% of cases 6 years after the IOL suturing using, as I said, 10-0 polypropylene suture. That's why some of the surgeons have used Jortex suture to discuss the risk of suture breakage, and that we will discuss it in the third episode of this series. Now, the intrascleral IOL fixation technique was reported by Gabor and Agarwal using sutureless technique for IOL fixation, and this technique can overcome the risk of suture also related. The risk of suture-related complication, it's been overcome by using glue to fix the haptics in the sclera. But this technique needs sclerotomy. So means that peritomy, opening the conjunctiva, and sclerotomy, and then implanting the haptics into a groove, and then put a glue and returning back the scleral flap, and then closing the conjunctiva. In Yamane, no, we don't need sclerotomy and we don't need peritomy. So Yamane and his colleague developed a new surgical procedure that can be carried out via the conjunctiva. So here we don't need a scleral flap or conjunctival or peritomy, means that opening of the conjunctiva, in which the haptics of the IOL are fixed strongly to the sclera without using suture or glue. They have named this technique as a flanged IOL fixation because they create a flange at the end of the haptics for firm fixation. By using double needle technique that can minimize the sclerotomy to 27 gauge and decrease the risk of postoperative hypotony. Now, I will show you a movie that's sent by one of my colleagues, because I'm not using the direct technique, I'm using the modified technique. And I believe that when we will discuss the modification, we will see that it's much easier, more stable, and it uses the double needle technique in a proper way. What we mean by double needle technique? What we mean by double needle technique is that we are using the first the leading haptics, that it will be externalized, the needle should stay there. We don't need to externalize and cauterize the haptics or flange the haptics before dealing with the trailer haptics. Why? That's because it will give us a good mobility, because we need an mobilization of the IOL inside when we are trying to externalize the trailer haptics. And we can see in this movie that the surgeon, he didn't use a double needle technique. He externalized the leading haptics first and cauterized it, and then he went to externalize the trailer haptics and cauterize it. Now, the surgeon was very expert in a way that the lens kept in the center, but for someone that he need to try and he need to start, my advice is to use the double needle technique. Now let us see to the movie. And that movie shows that the surgeons, he has a subluxated lens, so he used trocar, and we will come to what we need to use. Anyway, let us see to the movie, and it shows that the surgeon, he externalized that, he returned back the lens to the AC and freeing all the haptics, and then he rotated in a way that it will be in his direction. Then he did anterior vitrectomy to remove all the remnant of the bags, and he rotate, as I said, the lens in a way that it will be, and you can see he's using T forceps, and now he's doing the marker for 0, and then 2 millimeter from 0 on the right side upward, and on the left side downward 2 millimeter, creating tunnel. And here he's introducing the gauge 27, and he's using micro tying or serrated forceps micro to gauge 23, and externalizing the haptics. Definitely he supports the lens by his forceps because the two haptics is inside, and then he holds the haptics, and then using a very old cautery, and then push it and buried it. Now here he used iris retractor because the pupil was small, very narrow, so he used another needle, gauge 27, creating the tunnel 2 millimeter away from the limbus, and then now he's holding the other haptics and externalizing it and cauterizing it again. Now the pupil was very small, narrow, and that it's not the aim. Our aim is to make the pupil, see, this is 1 day post-op. Now, our aim is to dilate the pupil because that's one of the important issues to make sure about the centration of the lens. Now, let us go to the modification. Professor Kim from State published one paper showing the importance of the modification. That modification depends on the radical departure from the original Yamane technique, because the trailing haptics is fixed before the leading haptics. And this is the technique that I'm using, thus bypassing many of the technical challenges. The simplest solution is to externalize the leading haptics out of the eye through an inferior limbal incision. 6 o'clock. At 6 o'clock, we need to do incision And through that incision, we will externalize the leading haptics first. So when we will implant the lens, the leading haptics will be out and the trailer haptics will be out. And this will give us a very good support for the lens. And this is made even easier by using an one-step injector assisted technique. And that we are injecting, and in one hand, the assistant screwing the injector, and the other hand holding a microforceps, gauge 23, to grasp the tip of the haptics and externalizing it out. This maneuver secures the IOL from slipping too far posteriorly into the eye, and because the IOL site more anteriorly, access to the trailing haptics is enhanced for needle fixation. Now I will show you a diagram that I did it using simul eye, and simul eye we will see what's the address and how we can contact them to have this simul eye, and in my opinion, using for all surgeons that they need to start using this simul eye is one of the important step to start. Let us see this movie that I did it. As I said, we need a marker, gross marking on the patient while he's sitting on 0, 2 millimeter from the limbus, and then 2 millimeter on right side should be upward, and 2 millimeter left side should be downward on counteract in both. And this will be the site where we will put the scleral tunnel. So let us see the movie. In this movie, you can see that this is the marker where I put 2 millimeter from the limbus and 2 millimeter on the upper side. And then on the left side, see, I'm just showing that it should be on a 0 and 180, another marker, and lower 2 millimeter, that will be the tunnel for the leading haptics. So the right side will be the trailer haptics, the left side will be the leading haptics. Now we'll come to the needle. I'm using gauge 27. The first needle that it will be externalized, first it will be inside the eye, and that needle we will bend it 9 millimeter. If you will see, if I will return back to it to show the needle. See, so this needle 9 millimeter, you can see it very clearly. This, see, I'm bending it 9 millimeter because this needle will stay inside with the haptics. We will not externalize it. We will go to externalize the leading haptics. Then we will return back to externalize the trailer haptics. Now, the other needle, I will stop it and I will return it back. The other needle, I can bend it from the root, because this needle, as you can see, the other one, I can bend it from the root, the beveled toward the surgeon. See? Now that's very important. See? Now you can see how the beveled here shows that I'm showing that the bevel should be toward my site. Now we will take the lens, and under microscope, I'm showing that I'm trying to put the haptics into the beveled outside to see whether there's any difficulties, manufactural difficulties, anything that can happen. Okay? So make sure that the haptics going through into the needle easily, and see, very simple. Now, when I'm sure that everything is fine, I will go to the injector. 2 millimeter, 2.2, through 2.2 incision, I'm using the usual injector. making sure that the haptics is secured in a way that it will not be lost. See, I'm doing paracentesis, 6 o'clock, in a way that the micro needle, usually I'm using micro tying, and then I will inject the lens. Here, I'm holding the leading tip of the leading haptics, externalizing it outside. So we have two haptics now outside. So the lens is secured in a good way. So we need to create a paracentesis 6 o'clock and at 10 o'clock and 2 o'clock. So we have this paracentesis. I'm just showing you the technique in a way that everyone will see the difference between the original and the modified. So here we externalize the leading haptics out, and then the trailer haptics also in. Now the first is the needle that bent at 9 millimeter, and we will internalize the trailer haptics and trying to put the haptics into the needle. The bevel should be toward our side, and the tip of the haptics should be perpendicular to the bevel, and then we can pass it easily to be passed. The needle and the haptics left. Then I will do another tunnel by using the 11 millimeter bent needle. Here I need to internalize the leading haptics inside, very simple, and then holding the haptics at least 2 millimeter from the end, and then introduce it into the needle. As I said, the tip of the haptics should be perpendicular to the bevel, and then take it out holding. Now I will start creating the flange. See, this is the cautery that I should use. And then I create it. Now I pull the lens. I will externalize the trailer haptics, and now both haptics is being create a flange in it, and then now I can return it back and bury it into the tunnel, and that's all. So here there is an important question: what we need for this surgery? A very important sources is the lens. Now, this lens should have a polyvinylidene fluoride haptics. It's not a PMMA. Now, someone will say that, well, I'm an expert and I can use PMMA, polymethyl methacrylate, but I'm saying that this kind of haptics, it will be bend and crack, and we can lose it intraocularly. But polyvinylidene fluoride is the most suitable because it's nylon and it can withstand the bend. In spite of that, we don't need to bend it. So either we use Sensar IOL from Johnson & Johnson or Lucia from the Zeiss, or we can use any 3-piece PMMA, as I said. Now, needles, gauge 30-inch thin wall needle, that we can use it in Lucia. For me, I'm using gauge 27, and that I'm using it for Sensar. So each lens has different, so I need to test it outside the eye, then I will choose the proper needle for that, either 30 or 27. For me personally, I prefer 27. What else? 23 gauge micro forceps, whether micro tying or micro forceps. A 1cc syringe, as we said, ink pen, caliper, access ring, and cautery. This cautery that we used it for gentle cauterization, and this is unimportant. Now, we need for this technique either trocar for parspinal vitrectomy or AC maintainer cannula. So some surgeons, they prefer AC maintainer. For me personally, I use trocar because I feel that the trocar can give me a good handling to create the tunnel. That's why I prefer the trocar than the AC maintainer. Now, I promise you that we will go through and show you the Simul Eye, and Simul Eye is a very important tool. It has two in a pack of two, and it's cheap. And this is the site where we can go through and ask them, and they can send it to you. Now, our aim is to create this kind of flange, because this kind of a flange is an important. You can see that how it's not a big in a way that it will not go to buried into the tunnel, and it's not a small that it will slip from the tunnel. So it's in between in a way that it will be stuck into the tunnel and will not create erosion to the conjunctiva later on, which is very important. That's why I said that let me show everyone the shape of the flange in a way that everyone be aware about the size of the flange that we would need to implant it. Now, the second is the real movie. Now here, I had a patient that sent it to me with a the rupture capsule, and the surgeon, he left few lenses, part of the lenses inside. So I did a vitrectomy to remove them. But you can see here the gross marking of 0 and 180 and 6 o'clock. With the trocar having infusion cannula because this patient having a remnant of lens matter inside. So let us start the movie. The movie started with the 3 trocars because, as I said, there was some lens matter in. And then 2 millimeter from the limbus, the right side on the upper, left side on the lower, on counteract. Now I'm doing the needle. The first needle, 9 millimeter bend, and the second one is full, means that 11 millimeter bend from the root. Okay, now I prepare the lens and I test the lens for the haptics, and here I will recheck the peritomy, the paracentesis, and you can see that I'm using gauge 20 MVR to create the paracentesis, and that paracentesis, directions of it should be the right side, it should be toward the 6 o'clock, the left side, it should be toward the 0. And then main incision, methylcellulose, 6 o'clock paracentesis. Then the very important step that I will check the paracentesis for my intraocular forceps. It should be easily to go through. Okay? Now I checked everything, and then now, as I said, I hold the trocar to create the tunnel. The tunnel is a crucial here. We can't do it without tunnel, because that definitely will lead to rotation of the lens if it's not without this tunnel. So I left the lens here. Definitely we can start with the lens or inject the intraocular. So it start with the needle or inject the intraocular lens. It doesn't matter. Now I'm injecting the lens. See, I'm assisting the haptics to be externalized. Here I need to hold it from the tip. So I hold it from the tip and I got it out. The lens is rotated. That's why I will help myself to re-rotate the lens in a real direction. The leading haptics should be on the left and trailer haptics should be on the right. Now, here I have the needle ready for the trailer haptics, and you can see I will start with the trailer haptics, holding the needle. The bevel should be toward my side, internalizing the haptics, going to the paracentesis on the left, and then putting the tip, putting the tips perpendicular to the bevel, and then when I feel that the haptics is being stuck in the needle, I will leave. Now, holding the trocar again, which is very important step, creating the tunnel on the left side with 11 millimeter bend needle, and then internalizing the haptics, the leading haptics inside. Here it's inside now, holding the haptics at least from 2 to 3 millimeter. See, perpendicular, the tip of the haptic should be perpendicular to the bevel, which is toward your side, and then externalizing the haptics. And now I should have a gentle, see, I'm doing a very gentle flange, and then now I will externalize the trailer haptics. Again, I will do a very gentle flange, and then I will burying the haptics, and everything is finished. Now I will remove the trocar, and the surgery is finished. Now we can see that this is the eye of the patient post-op. I just dilate because just to see the location and the centration of the lens. Now I need to show you also the flange, how it's appear, and you can see this is the site of the flange, and it's under the conjunctiva, and see, you can see it, but you cannot, the patient will not feel it. So here we are. We finished this episode and this series of the secondary IOL implantation, and hopefully that this is our all social activity, and my pleasure to invite everyone to Dubai, to my city that I love and I lived, and hopefully that in this episode we cover all the issues related to this technique, Yamane technique. If there is any question or if any requirement, you can write to me under the in the comments, and we will answer all the questions related to you. Thank you very much.